My name is Abigail Carter-Langford. I have the pleasure of being the Executive Director of Health Information Governance and Chief Privacy Officer for Infoway. And I have an even greater pleasure today because I've got a fun group of folks who, from a diversity of backgrounds, who are going to share with us their insights on those big questions. So I'm a newbie to Infoway, and one of the pieces of Infoway work that I always consumed with enormous enthusiasm was a survey called What Canadians Think that Infoway has done every 5 years for the last couple cycles. And it's a great insight into what Canadians think about privacy in the context of digital health records. So I'm going to use that as a bit of a starting off point for some questions that I'm going to pose to our panel. And then my hope is that you folks will join in the conversation, catch the mic, and we'll have a good dialogue. So we're going to be quite informal, and I hope you will be too. So to that end, I'm going to sit on down and say hello to my panelists. I'm going to get us started with Kevin, if you don't mind, to be our bit of an icebreaker here. So Kevin McGee, as you'll see from your package, comes to us. He's a board member of Brant Community Healthcare System, but also a director of, it's got a very national director of the something cloud, all the good stuff at Microsoft. So Kevin, when we talked to Canadians in that survey, what we found was that Canadians by and large are quite confident that their EHR is in secure hands. And when we talk about security in the public space, often it's about things like inappropriate access, so someone who has access for a valid purpose but doesn't use it that way, or a breach, or something like WannaCry or hackers. Are we worried about the right things, and are Canadians right to not be that worried?
We need to be worried about breach and compliance and whatnot, but I always characterize it as, compliance is I walk between the lines when I cross the road. Security is I check both ways to make sure I'm not going to be hit by a truck. And they're two very different motions. So we need to make sure we do all the things around breach security and whatnot. But really, if a breach happens, the immediate impact to patient care is not obvious. What we're seeing now is, cyber criminals are not looking at extracting that data to sell it. They're looking at how else can I easily make money from these criminal transactions. And the easiest way is to deny you access to that data via ransomware. And we're seeing ransomware take on. And that introduces a new element of resilience to the hospital. If your hospital was completely shut down and you were not able to perform basic care because your systems were unavailable, how would you react? And a few months ago, this was a fictional scenario I presented, and then WannaCry hit and knocked out 16 hospitals in the UK. And I look at a lot of plans that hospitals have that say, we'll ship the patients down the road. Well, what if an entire region was taken out? So we need to think of security in terms of resilience and really focus on that as, can we sustain the mission of the organization if we were attacked? Not just look at sort of the breaches which the media focuses on.
So we also have with us Jill Clayton, the Alberta Information and Privacy Commissioner. Jill, does it surprise you when I talk about that finding in the survey that Canadians by and large believe that their information is secure in digital health records?
No, it doesn't surprise me. And I think that, in our office, a lot of what we're focused on obviously is compliance, and certainly it's breaches. We're starting to see more in the private sector incidents of ransomware and malware and these kinds of big hacks. In the health sector in particular, although we've seen a significant increase in the number of breaches that have been reported to us, most of those don't tend to be ransomware and malware. That's private sector. In the health sector, it tends to be things like transmissions of health information that have gone awry. So it's faxes and occasionally emails and things like that. And I think as an office, we consciously try to remember that what we are seeing is a very small percentage of the transactions that take place on a daily basis. If you look at something like Netcare with tens of thousands of authorized users, and the transactions, hundreds of thousands, if not millions of transactions taking place, what we see is actually a very, very small percentage So I think that generally, you know, if you look at the Health Information Act, I mean, that is legislation that is intended to facilitate the sharing of health information. And I think that Albertans can generally feel pretty secure in how that works. Having said that, we are seeing a spike in the number of unauthorized access cases, so snooping cases and offenses. And I worry about the chilling effect of those cases. Certainly when the media starts reporting on them, those are the kinds of things that make the big headlines. Yeah. And you know, I've certainly heard anecdotally about individuals who are reluctant to share really detailed health information if they're going to be worried about who might actually have access to that.
Yeah. So. And that was actually a theme that was picked up in our survey as well. I've been doing this work for a bit of time, and I remember in the early days reading some good literature that talked about how patients will withhold information as a consequence of that trust not being there. We saw a bit of that in the survey as well, where there were a good number of Canadians who reported either having withheld information from their provider, or having, and I smiled a little when I said this, known someone who does withhold information from their providers. And some of the reasons they gave were embarrassment, a perception that the information wasn't relevant to their care, and the very straightforward answer, because they didn't want their provider to know. Deborah, do you have thoughts on what impact that how prevalent you think that is in your experience? And Deborah Prowse is the Alberta Health Advocate in Alberta Health Services.
Certainly, we hear the concerns about compliance. We hear the concerns about the security of information. And we've certainly heard some impacts of where mental health information has been passed on through employment security checks. It somehow made its way into the police system. When the police were involved with a mental health check on the welfare or something like that. One of the things that we also hear, and I think we need to address, is the potential of bias in healthcare. And having certain information in healthcare can lead to differentiated care based on that information. We certainly hear a lot of that. And I've had a number of conversations recently about where else does our access go. And last summer I had a leak in my kitchen. I phoned my insurance company to see if it was covered as I'm standing catching the water dripping through my roof. And when I identified myself and said that's what I was calling about, the first thing that I was asked was, do you consent to the release of your health information? And I said, no, I'm calling about a leaky roof. Well, if you don't consent, we won't take your claim. So how is our information going to be used? And I think one of my greatest fears is if I phone and order a pizza, I'm told my BMI is too high. So I think there are concerns that we need to address really broadly from a patient perspective.
And you highlighted some, perhaps a worst case scenario of information aggregation. One of the topics we wanted to explore a bit with the panel is the extent to which, as we've heard today, there are great aspirations and great potential for aggregating the data sets we've accumulated about the citizens of Canada, the great potential to improve and augment their care and facilitate a better system, some very laudable, sensible objectives. So if we look at that as the objective, do you think our laws today are ready? And perhaps, Eric, we might start with you from the Ontario perspective. So Eric Sutherland is the Director of Information Management in Ontario.
Oh, thanks, Abby. So I would say from that perspective, my fundamental belief is, first of all, that we need to be focusing much more on population health and the things that we can learn from that in order to get to a place of preventing care in the long run, because we want to shift, much as we heard earlier on this morning about shifting left in the funnel from New Zealand. I think the same thing applies here. We want to be preventing as much as we possibly can, and that requires investments in population health. I think there's two levels of analysis around population health that we can do. One is at a macro level, just getting information about people, finding general trends in the population, and thereby setting up campaigns around these are ways to nudge the population. We'll hear about that later on this afternoon through the work that Carrot's doing. The other is in the mode where you take a population of people and you identify a cohort of people that could benefit from an additional treatment, and then have the ability to re-identify that cohort to be able to contact them directly and suggest something in that space. I think that the laws as they're set up right now, they're well set up for that first case, or at least somewhat well set up, although there are some challenges from access to researchers in that. On the second case, there are other challenges that we need to get through. I think one of the things that we have to consider, for example, in Ontario, I have accountability for the Personal Health Information Protection Act, PHIPA. And so one of the realizations that have come through as I've been in this job for the last 10 months is that there are opportunities there for us to enable, beyond the core use case of care for a patient being provided by a healthcare provider, but also for the researchers, the system planners, and the innovators as well as the population health analysts, that there are ways we want to make sure that we understand how those use cases would work, and then how PHIPA should operate in order to enable that. It may work within the construct as it is today. It may require some changes, and we're happy to work with our local commissioner in that space.
Jill, do you have any other observations around that? Because it's, when I think back to how I've used the law in Ontario as an example for research, it's been within some traditional constructs where you do have a research ethics board and identified question. Now as we explore how AI can be applied to big data, where you perhaps don't have a question, or you have a big question is what can I do with this data? It provokes a bit of tension perhaps with some of the traditional privacy methodology to say, well, what is your question? What's the least amount of information necessary to answer that question? So it's a bit of a paradigm shift. Do you think the Alberta laws are positioned to enable that kind of work?
Well, I think the Alberta laws are certainly that first layer of research. I think that the framework exists within the legislation. I think we probably see more issues around custodians being territorial about information, and process problems getting in the way. It's not so much. So it's a bit of a peeve sometimes when we hear that privacy is getting in the way and researchers don't have access to data. I don't think that that's not the intent of the legislation the way it's set up, but I think there's lots of room to make improvements. In terms of secondary use of information for some of the big data or the AI type projects, I'm a little bit concerned that our office doesn't hear a lot about those kinds of initiatives. I know they happen. I hear anecdotally about them, and there are requirements under the legislation. So again, under the Health Information Act, there are requirements to complete privacy impact assessments and submit them to my office. But we don't tend to see a lot of that kind of thing. So a lot of the questions that I have about how these projects might be going forward, and lots of questions around governance, around identifying the players, around what's the structure, how are decisions being made, what's the legal authority, how is information being de-identified, what kinds of technological solutions might be in place. I don't think that we have a really good handle on that. The legislation right now is, other than the mandatory PIA requirement, we're mostly set up to be reactive. So if a complaint comes in, then we can investigate it. But I think that some of these initiatives are so sophisticated, they're not particularly transparent to individuals. So the likelihood of an individual actually exercising their rights under legislation to bring a complaint is fairly low. So we've done a lot of work in the last couple of years to talk about information sharing initiatives and commissioned some research. There's a research paper on our website. We're trying to engage in those conversations conversations with the custodians that are involved in these kinds of initiatives, and especially when they're cross-sectoral. So we've got private sector, public sector, and health sector all coming together. But it's tricky. And I think, we've built this into our strategic plan that this is an area that we're interested in focusing on. We have some intention of having, facilitating some conversation in this area, in part so that we have a better sense of what's going on, and also so that we're better positioned to provide guidance to the players to make sure that these things are designed with privacy and security in mind at the outset.
Mm-hmm. Mm-hmm. And Kevin, this is part of your space as well, I understand, is talking about from a security standpoint and broadly how we might move in this direction.
I'm the furthest thing from a lawyer on this stage, so I'm a technologist, but a lot of the questions I get asked, imply that because I understand the underlying technology, I understand a lot of the legal aspects, and it's really eye-opening because a lot of our laws, again, I'm not a lawyer, seem to be built when we kept data in filing cabinets in locked buildings, and we still think of data that way. But data sets flow beyond our organization to third parties, and that's where a lot of the breaches and whatnot seem to occur. And we're not thinking about that integrated supply chain of data. And I think the only people that are going to do better than the cybersecurity vendors in the next decade are the cyber lawyers. And the case I always pose, when I speak to boards, is if a doctor who's not an employee of the hospital sends personal health information to his clinic using his Gmail account that goes through the U.S. On his bring-your-own-device tablet that he owns, litigate that. I have no idea what just occurred. So we get into these very complex environments now where we don't really understand even how the data is flowing, let alone how our laws applies to it. And it's just going to get more complicated as we look at data sovereignty issues and who has access to that data in a third party. The majority of the breaches we're seeing now in the cloud are misconfigured cloud entities of third-party contractors that the organization didn't even know was working for it. Right. That's not a technology issue, that's a governance issue and a leadership issue.
Infoway last year did some work around, was it last year? It was burgeoned into this year as well, I believe as well. And it was about data sharing agreements, because my understanding was that we were hearing a lot, and it's a bit like the privacy comment you raised earlier. We can't do this because of those data sharing agreements. And one of the messages I took from that report was, it's not the agreement, just like it's not the privacy. It's if you try to describe and define governance about a complex initiative with multiple parties spanning different sectors, and you try to do that over an agreement, or you try to do that at the end stage when you're looking for a privacy approval, naturally it's not going to be pretty. So it's not the agreement, it's not the privacy, it's what I'm hearing from you folks is it's those fundamental questions of who are we working with, how are we working together, and what are we going to do with this data? And that is a difficult conversation to have in the later stage of a process, project, or initiative. Go ahead, Eric.
One of the things my group are actively thinking about how to restructure data sharing agreements and provide some leadership around it in Ontario. And one of the specific constructs that we're thinking of is separating it into there's the legal agreement, and this is the thing that we'll get those lawyers and pay them lots of money to do it, but can we do that once for a large swath and come up with more master agreements? I know this is something I believe is happening out in BC right now. Whereas then the operational agreement, that's the agreement between parties about what data you're going to share. And that's something that is more operational in its nature. The whole data sharing agreement process gets thrown under the bus a lot, much as the same way that privacy gets thrown under the bus a lot. A large part of the issue is education. Yeah. Around what the actual problems are, the time that it takes to actually, the data sharing agreement process signing off is the long pole, but it's the negotiations that occur along the way around understanding the problem, et cetera. It's not the actual agreement, it's the process of getting to agreement about what you're actually going to do. And so I think that we're doing somewhat of a disservice in not educating people more about what the actual problems are. And then given what the actual problems are, instead of just throwing the whole thing out of the bus, how can I actually segment that off and solve and meaningfully solve a component to make it simpler for everyone?
which might be a lovely definition as a replacement for what is sometimes, I think, an overused word in the spirit of our conversation this morning around innovation, governance. So you just described, again, what are we doing, who are we doing, and how are we doing it?
I think
Please.
from a patient perspective, at least the patients that my office hears from in Alberta, patients believe there is already sharing going on. They're surprised that they have to tell their story when they get to ER, that they have to tell it again to their family doctor, that they have to tell it again to the specialist, that they have to tell it again to physio. They're very surprised when they find out that we're not connected. And I think they believe we've got it all worked out. So all of these things are all done, and the sharing is going on. So educating the public and patients is a huge aspect of this.
Right, right. So one of the elements of the questions in the survey around patients' comfort was also questions about what gives you concern. And a relatively small number of folks expressed a concern about researchers at university having access to their health information, and a bit more expressed concern about private sector participants having access for research purposes. So, Deborah, you used a wonderful example of your insurance company and horrified me at the prospect of me being cut off from my pizza delivery service, which is a real concern.
Could everybody de-tweet what just went out about my BMI?
Do you, in your encounters, and this may be perhaps thrown by your role within the Alberta Health Advocates Office, but do you hear a lot of that dialogue and tension from the patients you serve?
I think we haven't heard that yet because people don't understand what big data is. They don't understand what secondary use is. And they don't understand de-identification and what that is. So we aren't hearing a lot of it now because I think people just don't see it on the front coming towards them.
Right.
So I think that's something that, we talk a lot about e-health and m-health and virtual visits and all sorts of things. I think we really need to step back and create e-patients. And the e-patients, and e-patient Dave is a great model of this, enabling, engaging, empowering, equipping, and then making equal partners of our patients so they have all the information they need. We need to be talking to people about what secondary use is before we expect everybody just to accept it.
Right. So the question I was planning to close with, but you've started to answer it, is what do we do to further raise the level of assurance? Because when I was looking at that data in the survey, one of the things I was struck by was back in 2007, there was a reasonable level of assurance. Our citizens, Canadians, trusted the system, trusted the sector to handle their information appropriately. And we've seen that steadily rise and healthfully rise, even though we're now bringing into play greater complexities like big data, secondary use more prevalent, and digital health tools are more available. And still in the media, there are more of these snooping stories. So despite all of that, confidence is rising. So you think to increase the trust of Canadians in their health system, the answer, and privacy in their health system, I should be more specific, a greater dialogue.
I think absolutely, education, information.
So before I ask our colleagues that, I think it's perhaps a good moment. Are we ready to throw out the mic to the floor?
Sure.
All right. So Caitlin's polling for a mic. Oh, sorry, there we are. So does anyone want to be the icebreaker? Ah.
Where's the little orange present?
We're going old school right now.
Hi, everybody. Thank you for the presentations. My name is Iris. I am a patient partner, Patient Voices Network of BC. I sit on a number of committees, including the Doctors of BC, 2 committees with them. I sit on eHITS with Kendall Ho, Tech for Home with Kendall Ho. I am also a facilitator for chronic conditions. Now, my question is, and I hear this so many times, I'm working in a workshop, I'm mentoring one right now. The medical profession seems to, with patient information, patient files, one doctor to another, it's like, this is mine, and you can't have it even though I'm referring the patient to another doctor. Now, somehow, we've lost sight that that information isn't yours. It belongs to the patient. And you need to either, like you say, create an e-patient portal or something. Somehow the patient shouldn't be the one made to suffer. What's coming up that's going to allow you to either share this information or give it to the patient so he can or she can share it with whoever they need to? Thank you.
So that's a great question. So, and I'd say some applause for that is warranted. Well done. It's funny when privacy does get used as an excuse not to share data, because of course there's that instinctive answer from a privacy perspective is it's the patient's. Your fiefdom doesn't apply here. So how are we doing in terms of making that core belief more prevalent in the system?
I'll talk about it a bit from the Ontario perspective. So first of all, absolutely agree with everything you just said. One of the things as I've been wandering around talking to people in Ontario is that privacy needs to be more like a Quebec highway, where there's a maximum speed limit, you can share too much, and there's a minimum speed limit, and we can share too little. And frankly, we are sharing too little, far too much, for all perspectives. A big aspect of sharing is Ontario's adopted this Patients First digital health strategy, and that's really all about enabling better access to electronic health records, better coordination among hospitals, better coordination among primary care doctors. And a lot of that is trying to get people, because as things have grown up in the last many years, we allowed the various healthcare practitioners to fragment and fracture the infrastructure and the data on which they were residing. So you might even be in a situation where two doctors wanted to share information with each other from the primary care practice, but couldn't because the underpinning technology wasn't compatible with each other. And so that's why what we're trying to do now is to say, how do we design the infrastructure to make it easier for people to share? The acknowledgement that the patient owns the data, in my mind, it's absolutely clear, and it's something very much echoed with our privacy commissioner as well, so we're very much on the same page there. And we're trying to get through some of the technical challenges with it right now without printing off tomes to actually share the information. But it's a real challenge because we're burdened with 10, 15 years of decisions that enabled fragmentation rather than bringing data together.
Commissioner Clayton?
Well, I would agree with that. Certainly what we see through the privacy impact assessments that are submitted to our office and some of the consultations that we engage in is, and just stepping slightly outside of health and moving into just information sharing initiatives in a more general way, we do see, and as I mentioned earlier, one of my big peeves is hearing, well, we didn't share information, something tragic happened, privacy laws got in the way. Yeah. I think maybe there is room to be tweaking legislation to facilitate sharing, but as a privacy commissioner, I certainly get that information needs to be shared in order to provide programs and services and to deliver healthcare. As I mentioned earlier, that's sort of the principle that underpins the Health Information Act. But again, from some of the privacy impact assessments that we see, the challenge is not the legislation. It is things like technology. Yeah. We're probably uniquely positioned as a result of having seen 5,000 plus PIAs over the last few years since the Health Information Act came into force, to be uniquely positioned to sort of put together all the pieces of the jigsaw puzzle that make up the information systems that support the provision of health services in the province. And it's complicated, it's sophisticated technology, but getting systems to match up. Even for, say you've got a clinic and they're using a particular EMR, to switch to a new EMR and migrate data. I mean, just the devil's in the details. These are tricky things. Sorry.
Please. So just because actually the first almost the first two words in our title were around data governance. And
Yep.
we haven't really touched on it very much, and really it's around, because even different practices can have different data standards for what data they're actually capturing and how they capture it.
Yep.
And different levels of quality in which they assert the information, and ultimately how that changes over time. As I know we're dealing with in Ontario, and imagine other jurisdictions, we're now looking at sex as a field, which is about individual, and now we're thinking about, well, we're going to have two fields, gender
Yep.
and sex, about mental versus physical. And that change and how that change propagates across the province is enormously tricky.
Yep.
In terms of both how you capture the data, how you propagate it, and how you collect it centrally in order to enable it for all the various sorry, I try to use analytical use as opposed to secondary use, because secondary makes it sound secondary.
Yeah.
And it's really, as I said earlier on, my opinion is that population health is essential, and that's part of that bucket. So analytical use. And just try to move that stuff forward.
So, Caitlin's point, oh, wonderful. Sheila's holding it.
I realize this might not be popular asking a privacy panel, but I want to get back to the point that you made, Deborah. You mentioned that you don't get very many folks coming to your office talking about data and big data because they don't understand it yet, and the secondary use and all the implications of doing that. And I want to push back on that, because I wonder if they don't understand it, or they just, it's not something that's hitting their radar. I mean, Google, my Fitbit, the data is going everywhere. So again, I think the keynote this morning said that privacy is the biggest excuse not to share information. And I'm not sure that data, people get it. People are giving their information, or they're making it available all the time. They understand that Google and you know is using their data to say, well, if you read this book, you might like this one as well. I think that's a part of life. And so I'm wondering a little bit in healthcare, and I recognize that, you know, Eric, you said it well, there's a minimum speed and a maximum speed. There's somewhere in the middle. But I'm just wondering if the panel can sort of comment on that a little bit, because I'm not sure that big data in health is any different from big data in other places. As I'm saying this, I'm thinking, no, you're digging yourself further and further into the hole, maybe being a little bit provocative, but I'm wondering if the panelists can talk about whether big data and analytics and use of data is really a concern or should be a concern to Canadians.
Can I start?
I would like to say that I think, Sheila, it's a generational thing right now, because I'm not sure many of my peers understand that when you use a Fitbit, that information isn't just going into your wrist, it's actually going back somewhere else. And I know of many people that haven't clued on that because they were Googling something, now they're getting all these ads related to what they Google, and they're thinking, you know, isn't that funny? I was just looking at something, you know, like, isn't that funny how that happens? I think the next generation is going to have that much more understood. But I think there are many of us that don't have that understanding yet.
Kevin?
And I don't think we have any hope in the next generation either. So who brought a cell phone here today? Raise your hand. Who has Bluetooth or Wi-Fi enabled on that cell phone? Even know? Don't bother giving me your business card. I already know who you all are. Who connected to the hotel Wi-Fi without a VPN today? Come on. Okay, you don't have to put up your hand. It's all right. Who connected at Starbucks? You know, who uses a home internet provider without a VPN and encrypting your data traffic? Everything you type is going into someone's big data pool out there. You're abdicated in every second. You are moving around different locations. You're being tracked by your cell phone. It is happening, and we're completely unaware of it. So it's not just in healthcare. And when you type something into Facebook and you backspace and don't hit send or post or whatever it is on Facebook, they store that information too. All your searches and content is all going in there. I don't think any of us understand the nature of what privacy is becoming. So to say that we can figure that out in an industry that is generally far behind in terms of governance and legal aspects, we're always going to be catching up, and it's going to be an exponentially growing gap, I think, in the coming years.
Well done, Sheila. We've got a conversation. Eric?
So I'd agree with all that, and I listened to a podcast last week, and that was more or less trying to convince me that Facebook was listening to me through my computer because of the ads that would show up based on the circumstances of things that it would otherwise know and then determine, show this ad. I think what's different about health, though, is that there's more implications of breaches or information about my health. And thereby, I think that's why there is a heightened sensitivity. I don't care if people know that I've done 2,532 steps today. I do care that they know that I'm ill or have had a cancer diagnosis in the past or something like that, because that can actually impact how they treat me and deal with it in a particular way, or my other socio-demographic factors. So I think that there are some things that there is a heightened sensitivity, and so it's not as simple as general Facebook demographics.
But we do see then people posting the medical records to patients like me, and because they want help and they want that information shared. So, or providing their run data for the day and whatnot, and wanting to make that information available from your Fitbit to a doctor who won't take it because there's no way for them to consume that information.
Right.
So the nature of privacy is really going to change.
Yeah, I think, and it's really centered around consent. And to the extent that you want to opt in or opt out of consent models for how to actually engage with the healthcare system, I think that we need to find a way to make it easy for people to make a determination about how they want to act, as opposed to do it on a case-by-case basis.
Commissioner Clayton?
Oh, I just wanted to add just further to this this discussion about what are people aware of. We actually back in 2012 had done a general population survey, and we just redid it again, but the results aren't out there. But they will be shortly within the next couple of weeks. But one of the things that we ask the population, the general population about is we provide them with a great long list of, I don't know, there's somewhere between 25 and 30 potential privacy topics, and say, which of these are important to you and how important are they to you? And that includes things like de-identification and big data and that sort of thing. But consistent with the survey that we did back in 2012, the top results are identity theft, fraud, hacking, malware, ransomware, phishing, and inappropriate access. So all of those traditional kinds of things, big data, analytics, de-identification, those issues are way, way, way down the list from the survey that we did of the general population, and what are they concerned about when they think about privacy.
Perfect. Elaine.
My name's Catherine Hana, and I'm a nurse, and at the risk of ruffling some feathers, I'm going to build on Sheila's question, because we did hear this morning about privacy, and the statement, I believe, if I got it accurately, was just sort it. And I've been around this business for a lot of years, as some of you know, and these are the same issues we've been beating our gums about since we started down this track. So when are we going to sort it? And how are we going to do it? And I think we also heard in terms of mixed messages earlier, most patients think we've already got the information, and we don't, because of all these hurdles that keep being put in our way. So I think technology is an excuse. It seems to me the legislation being outdated is an excuse. So what's the real problem about why we can't get this sorted out in this country?
Well, that's an interesting one. So I heard, one of the, and perhaps I was hearing what I wanted to hear this morning, but one of the little snippets I heard from Andrew's talk this morning was people pull out these issues when they want to defend the fiefdom. Is that because I've heard from the panel, we're feeling like there are laws in place, there are patient expectations that tell us this is the right thing to do, and there are right ways of doing it. I've heard that while our laws have naturally the same opportunity for modernization that we all have, that there is a path forward. So is privacy and perhaps now security another excuse? And how do we call people on that more? Do I need to start wearing a t-shirt as a privacy professional that says, don't come to me just because you're looking for someone to say no? That's not very catchy. I'd have to come up with something shorter. But what is the answer to that very age-old question of shifting the paradigm? How do we continue to build trust and take away the excuse? And forgive me, Eric, you're a familiar face, so I look to you
No,
first.
I'm deeply thinking right now, Abby. I think it's an excellent question. I don't know if it's an advantage or disadvantage of being new.
Yeah.
I've only actually been in healthcare for 10 months, having come 20 years from working in the financial sector. My passion is really around data and information and bringing it to life. And I think part of the challenge, if I can put it this way, and this is just my personal observations on things, is that we haven't really had, and I'm not sure to what extent this is true in Ontario or across Canada, but certainly my observation, having talked to people in Ontario, is that we need to be thinking more about how do we create trusted information, provide access to it, to generate insights that drive action and enable outcomes. Mm-hmm. And if we have those 5 things together, then we can actually do fantastic things. And then obviously the outcomes then generate more trusted information that create that cycle and over again. In the context of the question, I think that we've been focused too much on singular parts of that chain, and we haven't thought about it holistically. We've been thinking from a big data perspective, we can get cool analytics. Let's all invest in Hadoop and get our infrastructures and further fragment our data infrastructures. Let's invest in these technologies to get these things done. Oh, by 1 second, you can't actually do anything because of privacy, and that chain falls apart really, really quickly. If we focus on it in those 5 paradigms, I think that, and we start to think about, well, where do we want it to go from a patient perspective in terms of the outcomes we want to be generating for them? What are the actions that clinicians and providers and everybody can create that then inform what insights we want to have, which then in turn tells us what information we need to collect and how we provide access to it? I think that in of itself, in a designed way, we can start to say, well, that's where we want to go, so how do we make sure that every investment we're making along the way gets us there? I'm looking for, in a case in Ontario where, again, we have these 145 different hospital platforms that are all, even though many of them are actually on the same platform, are unique versions of those platforms. Mm-hmm. And now we're saying, no, we're actually only going to subscribe to a smaller number, and we're going to try and encourage the hospitals to cluster together into larger consortiums. We're not yet at the point of saying, I think in Alberta you guys are saying you have one for the entire province, which is brilliant on your part, by the way.
I'll take credit.
Take that one. And so from that perspective, I think while I hear what you're saying in terms of the technology and privacy are excuses and what's the real problem, I think the real problem is that we haven't actually designed it from what the actual outcome that we want is. And as a result of that, historically, we've created problems of technology, and we're hiding behind privacy as a way to not solve that endemic problem.
Yep.
And so really, if we start to think about trusted information and access, not privacy, access in a privacy-enabled manner to create the insights, drive action, and create the outcomes, I think then we'll actually be able to get somewhere.
I've been at working tables recently where a member of Jill's office has been at the table, has totally changed things. Has
For the
totally
better.
knocked down
In a
a
good way.
barrier.
Yeah.
Even from the vendor process, I mean, we build an RFP, we issue the RFP, and then we sit in rooms trying to interpret what you were actually asking for and how we can price it to win.
Yeah.
There needs to be more collaboration, and that has to be fair and trusted and transparent. But what if there's a little startup in Winnipeg that can solve this problem? It's completely does not have access to the market because of the onerous procurement processes that we built and the bureaucracy around it. So I think we need to find innovative ways to work with the private sector to solve some of these problems as well. And we're going to have to maybe accept some risk or find new ways to do it.
Yeah.
So that's a good note to end the question on. Don't blame privacy, blame the procurement guys.
The other piece. So that's the other excuse that we'll get to later on.
And don't attribute me to that tweet.
So I promised to end in 2 minutes, but I think we have room for one final question. I've got we're right here. Forgive me.
Hi, my name is Amal Kapoor. I'm a cardiologist here in Calgary. I happened to know about a conference only yesterday. Share some experience in Alberta, what we have. And I founded and have a company in health IT, and the challenges came along. Privacy is just a false assurance we have as a doctor. And when I went through my own research, trying to find out the privacy acts in Alberta, what we have in federally, it is a pseudo assurance we have. Privacy getting breached along the way so easily, every day happening, but it's just not out in the media. And the health system is very insecure, even including Netcare from Alberta point of view. When I asked my IT guys to look into Netcare, how secure is that? This is the least secure. FinTech for TD Bank probably is more secure than Netcare. And how technologies fail. And one example is that there is a app developed by Meditech, doctor-doctor referral. And Alberta Health Services failed it because the referral was supposed to referral has to be initiated through Netcare. Does not have to be initiated from outside vendor. So it failed because GPs don't refer to GPs. GPs refer to specialists. And specialists all work in hospitals. They can't get referrals because AHS mandated that because of privacy concerns. And the same time, when I was going across Canada, I was finding it was very challenging to move this privacy policy what we have in Alberta, and then we have in Manitoba, what we have in Ontario. And why can't we have one federal level, one privacy policy, and everyone just follows that? Why do we have to go through this bureaucratic process for each province, each city, each healthcare system, again and again and again? What it does, it delays technology. Technology is moving ahead, but healthcare system by the time it makes a decision after 2 years, technology has already moved on. Any
So,
comments on that?
I should have prefaced with, we had 2 more minutes, an easy, gentle question would have been good. So I'm going to suggest that provoke an ongoing conversation throughout. So I heard a combination of that the privacy processes and systems we have in place are challenging as a barrier to entry if you're trying to move in practice. I've heard that the systems and processes and technologies are advancing very quickly, so it's hard to keep up from a security standpoint. And there was a lot more packed in there as well that we can continue the conversation after. But to the folks on the panel, is there any action or thought that you want the folks in this room to leave with?
Well, I'll simply say, starting tomorrow,
Yeah.
Abby
Yes.
is chairing a group called the Health
Yes.
Information Privacy Group. So I'll just call that out. So we're meeting for a day, day and a half with the various commissioners. And I think that's a very interesting conversation. So that group meets periodically in order to be able to have those types of conversations to say, how can we synchronize this across the country, recognizing where we want, there is some local autonomy, but there is value in broader coming together and things like, for example, mature minors, First Nations, and other such things as well. So I think it's there is the forum, and I think using that forum more so to further some of these difficult conversations about how we enable data access for all purposes in this increasingly interconnected and data-centric world. I think it's essential.
Thank you for the plug. So, shall we give the last voice to the voice of patients? That was terrible.
That was it.
So I'm interpreting that as there are always going to be great questions from a privacy, security, and governance standpoint. So thank you for giving us 45 minutes of your wonderful and esteemed thoughts. And it sounds like we're going to have some good conversations out in the hallway over a coffee. So with that, we'll call it a do. Caitlin, can you remind me, do we get a break? Oh, we got her queued up after. All right, so thank you very much.